So I have no disclosures. So as we know that congenitally corrected transposition of the great arteries, or cc-TGA, is a rare congenital heart disease that has a unique anatomy and physiology. Atrioventricular connection is discordant, so as ventricular arterial connection. Therefore, right ventricle is working as a systemic chamber. There are many coexistence anomalies such as ventricular septal defect, LV outflow tract obstruction, tricuspid valve abnormalities such as Epstein disease, and mitral valve abnormalities. Symptomatic presentation will be determined by the severity of coexisting anomalies. So there are two types of surgical options for the biventricular repair of cc-TGA. One is physiologic repair, in which physiologically corrected. Another is anatomic repair that makes anatomically corrected. For anatomic repair, double switch operation is performed. Atrial and arterial switch operation are performed in patients without pulmonary stenosis. If no VSD or small VSD, LV training by means of pulmonary artery banding is performed. It is recommended to perform at earlier age, as you know. Atrial ventricular switch operation is performed in patients with pulmonary stenosis. Just briefly showing the surgical technique for the arterial switch or Jaten procedure. As you can see, after transection of the great arteries, coronary arteries are re-implanted, and then great arteries are switched. This is a Senning procedure, one of the atrial switch operation. Basically, systemic and pulmonary venous rerouting are performed with atrial septum and wall. In contrast, autologous pericardium or other kinds of patch were used in mastered operation. So Rastelli procedures consist of left ventricular outflow tract rerouting by VSD closure and reconstruction of right ventricular outflow tract, usually by the conduit. So physiologic repair is a relatively simple procedure, such as VSD closure, tricuspid surgery, or reconstruction of LV to PA. So the biventricular repair for the cc-TGA has potential long-term problems. In patients having anatomic repair after LV training, LV dysfunction, mitral valve incompetence, ventricular arrhythmia, and AV block are issues. For the mastered and Senning procedure, atrial arrhythmia, SBC-IVC stenosis occlusion, and baffle leak. Jaten procedure has a risk of neo-AR, especially after the PA banding, and also for the coronary ischemia. After Rastelli operation, as you know, LVOTS, conduit stenosis, and ventricular dysfunction is an issue. For the long-term problems after the physiologic repair, the concerns are the same with the natural history in patients without VSD and PS, so RV dysfunction and tricuspid regurgitations. I'd like to look at some literature. This is a study from Cleveland Clinic, looking at 240 patients who were treated between 1995 to 2000. Surgery included 79 anatomic repair, 45 physiologic repair, 24 Fontaine, and 6 primary transplant. On the right side, you can see that transplant-free survival after surgery was similar among the groups, but after 12 years, patients with a physiologic repair had a decreased survival compared to other procedures. So this is a Kaplan-Meier transplant-free survival by age at surgery in patients having anatomic repair, which showed age at surgery was not associated with mortality. So these figures show the prevalence of left ventricular dysfunction after the anatomic repair. On your left, you can see 28% of patients having anatomic repair had LV dysfunction 10 years after surgery. On the right side, you can see LV dysfunction occurred in about 30% in patients who had a repair at age of 5 years, compared to only 10% in patients who had a repair at 3 months. I'm not sure why they divided the group like this, but it is clear that the younger age repair is better in terms of maintaining LV function. So this is a study from Boston Children's Hospital, including 128 patients. So they had 37 patients double switch operation and 91 non-double switch operations, such as palliative surgery, including PA banding, tricuspid valve surgery. Kaplan-Meier curve shows freedom from composite endpoints, including death, transplant, systemic ventricular dysfunction, AV valve regurgitation, were better compared to non-double switch patients, but did not reach to the statistical difference. But it just may be difficult to compare two groups because initial presentation age was different between two groups. So they adjusted by age at first presentation and also by AV block, severity of tricuspid regurgitation, RV function, and now you can see double switch patients are significantly better compared to palliative surgery patients. So this paper also showed the important findings, which is LV dysfunction after double switch operation. As you can see on the red circle, prevalence of moderate or severe LV dysfunction is more often seen in older patients in this cohort, indicating the importance of earlier timing surgical intervention. So this is a Kaplan-Meier curve from composite endpoints in patients under the 5 years, adjusted by the TR grade and RV function, showing patient with a double switch operation had a lower chance of developing the composite endpoints. So this paper suggests double switch operation in patient with a TR and RV dysfunction at earlier timing. So how about outcome after the physiologic repair? This is a study in 1990s from Netherlands, including 73 cases having a physiologic repair. With a follow-up of 12 years, the overall mortality was 11%. RV function, TR, were worse compared to the non-surgical patients. So this is a study from Osaka, Japan, looking at a patient with a Rastery type physiologic repair. This study showed a lower LV to RV pressure was associated with the tricuspid regurgitation. Important findings in this study is that conduit stenosis prevented progression of TR. So this is a study from Boston in 2005, looking at physiologic repair in 123 patients. On the left side, you can see patient with a heart block had a lower survival compared to the one without. On the right side, patient with a Fontan operation had a no mortality. In contrast, patients who had tricuspid valve surgery had only 40% of survival rate at 10 years. So this study showed RV function decreased soon after the surgery, while the tricuspid regurgitation developed after 5 years. So this is a study from Tokyo, Japan, which included 189 cases. This study showed equivalent survival between anatomic physiologic repair, and they recommended anatomic repair for patients with a significant TR. This is a multi-center study from South Korea, including 167 patients. When looking at the procedure, most of patients had a Rastery type of repair, both in physiologic and anatomic repair. Results are excellent with 83% survival at 25 years. There's no difference in survival between anatomic and physiologic repair, which is shown in the right upper figure, and freedom from reoperation and arrhythmia were also same between the groups. But looking at tricuspid valve function, RV function, as well as systemic AV valve function and systemic ventricular function, anatomic repair group was significantly better compared to the physiologic repair. So prevalence of systemic ventricular dysfunction and systemic AV valve regurgitation was lower in this study, probably because most of patients had a high LV pressure before surgery. So this is a recent review paper comparing anatomic physiologic repair, included 44 studies, 1,857 patients. So as you can see, there was no difference in the operative mortality, in-hospital mortality, and post-discharge mortality. So, reoperation rate and systemic ventricular dysfunction was significantly lower in anatomic group. When looking at the type of surgery, there was no difference between the Senning-Jatin and Senning-Rasteri type operation. On the contrary, the operation was much higher in Senning-Rasteri group. So it is important to note that we may not want to compare these types of surgery because the underlying diagnosis is completely different. So I'd like to show our experience in Okayama University Hospital. We had 43 patients from 1997 to 2019. 3 patients had a bilateral SBC. So all 12 patients who did not have VSD received a PA banding and underwent double switch operation later on, incorporating Senning and Jatin, except the one who had 1.5 ventricular repair for the bilateral SBC. Patient with a large VSD underwent Senning and Jatin. For patient with a VSD and PS, 11 patients had a Senning-Rasteri type double switch, and 9 patients had a Fontan. 4 patients had a 1.5 ventricular repair, and 3 patients had conventional physiologic repair. So this is the outcome in each group. For patients having a Senning and Jatin type operation, mean age at surgery was 6 years. No patient died. Follow-up was 10 years, and reoperation needed 3 patients. 1 is for the AVR. Functional outcome was excellent, with no one had LV dysfunction. 2 patients had a moderate AR, and these are the one who had a large pulmonary valve before double switch operation. They are in a good status with a good NYHA class with a reasonable exercise tolerance. So 5 patients had a 1.5 ventricular repair at median age of 9 years. There was no death and no reoperation. So the Senning and Rasteri type repair were performed in 15 patients. There were 2 early deaths and 1 late death. As you can see, the reoperation was needed mainly for the RVOTR reconstruction. So functional outcome was excellent, with no patient had AV dysfunction. NYHA functional class was 1 in all patients, with a mildly decreased exercise tolerance. So 9 patients had a TCPC. There were no deaths and no reoperation. All but 1 had a good ventricular function. Fontan pressure was 11 mmHg with an EDP of 6 NYHA class was 1 in 7 patients and 2 in 2 patients. We had only 3 patients who had a physiologic repair. There was no death and no reoperation, but 1 patient had decreased RV dysfunction with a severe tricuspid regurgitation. So we need to carefully follow up this patient. So this is a freedom from death ventricular dysfunction. Approximately 80% patients are alive without good ventricular function. So freedom from death or systemic ventricular dysfunction in anatomic repair was about 86%, which is excellent. So left-hand panel shows the freedom from death ventricular dysfunction in patients having Senning J10. No one died and had ventricular dysfunction. The right hand shows patients having Senning and Rastelli type operation, and ventricular dysfunction was seen in about 25%. So I'd like to finish my presentation with this slide. So based on the literatures and our experience, biventricular repair should be considered with this surgical algorithm. No question to go for the double switch operation in patient with a pulmonary stenosis atresia if VSD closure is feasible. Physiologic repair can be an option for the patients who are not suitable for the VSD closure or not having VSD, but older patients such as teenager with a significant TR, if any. Double switch operation should be considered in patients, smaller patients such as infants and small children. It is still in debate whether or not we go for the surgical repair in patients with no VSD and no TR due to the lack of evidence. Thank you for your attention.